Good morning, everybody, and welcome to this morning webinar on congenital vertical talus. We just wait a few seconds to enable everyone else to join in. Just to let you know, for those of you that have not been or haven't participated in a Zoom webinar, there is at the bottom of your screen a Q&A section, and this is how you can send your questions. We're gonna have at the end of the presentation, we're gonna have 10 minutes on Q&A, so do please send your question once we have finalized, we have gone through the PowerPoint presentation with Denise. For those of you that are unable to join us by the video and are joining us by the phone, you can send your questions to info@steps-charity.org.uk. Now, those of you that are online through Zoom, could you please send your questions so that I know that it's working, or not questions, but sorry, if you could just send a hello to know that the Q&A section is working fine. Okay, perfect. Yeah, I can see people are sending their hello. Hello back to all of you. Thank you very much. Perfect. That is great. So I can see that it's working fine. With regards to your videos and your ability to speak, please bear in mind that both video and the speakers are off. So do not worry or do not panic if you don't know how to switch them off. My name is Loredana Gwetch-Wyatt, and I'm the Managing Director of Steps Charity Worldwide. And I'm very pleased to have here with me Denise Watson. Denise, do you want to do an introduction?
Hello, yeah, I'm Denise Watson. I'm an advanced practice physiotherapist in Paediatric Orthopaedics at Chelsea and Westminster Hospital. And I run a sort of basically clubfoot and foot deformity, lower limb deformity service at Chelsea and Westminster. Thank you very much, Loredana, for asking me to come and have a chat about congenital vertical talus today. Really, the point of this is to answer any of your queries and questions, particularly around this time with COVID-19 and limited access to hospitals and treatment. And I know there'll be some of you out there that are very anxious about delays in treatment with your children. But I'd like to try and answer any of your sort of concerns and queries, and any basic concerns or queries you have about congenital vertical talus.
Thank you, Denise. Should we start with the presentation? Those of you should be able to see the presentation that we are sharing at the moment. Please do let me know if you have some difficulties in seeing it.
Lovely.
Perfect.
I thought I'd start off with just running through what congenital vertical talus is, some basics about the treatment, and some pictures so that we can sort of stimulate some questions and hopefully maybe answer some of your questions on the way. Do you want to do the next slide, Loredana?
Thank you. And for those of you that are on the phone that can't view it, we are recording the webinar, therefore you will have an opportunity to go back and view the slides later on. Sorry, gone too far. There you are, first slide.
Okay, so congenital vertical talus, CVT. There are slight variations in the incidence quoted, but in Matt Dobbs's article in the JBJS, he was quoting 1 in 10,000. So it's quite a rare condition compared with clubfoot, for example, which is 1 in 1,000. So 1 in 10,000. It's thought that at least 50% of children with congenital vertical talus have another condition associated with it. So it's very common to have congenital vertical talus and another condition. And I know that there have been some questions about this already. So those other conditions can be divided up. So you tend to get the skeletal conditions such as arthrogryposis, which I guess is a neuromuscular condition as well, or spina bifida. It's very common to get congenital vertical talus and spina bifida, and these tend to be very severe congenital vertical talus feet, very stiff, severe. there are quite a lot of syndromes that have vertical talus associated with them. And I mean, they are rare syndromes. And so going through giving a list of names probably isn't terribly helpful. But one of common factors with children with another condition with CVT is that it's very common to have developmental delay. They're often picked up a little bit later, the additional diagnosis. So it's often not clear at birth. You can't tell whether a child's got developmental delay necessarily right at birth. There's also thought to be an association with the autistic spectrum. So there are a multitude of different conditions. Laura Dana and I were talking about this earlier, and I was saying, you know, the treating team will be looking out for looking at your child holistically, and the best pathway is referral to a paediatrician if it is felt that there is another underlying condition that needs investigation.
Thank you, Denise.
Next, please. So it's a little bit complicated, the deformity. This is a picture of a newborn foot with congenital vertical talus. And I just want to show you on this model, so very nicely in this model, this grey bone here is the talus. And it's like the sort of main moving structure within the foot. So it connects the long bones of the shin to the heel bone and to the front of the foot. So it's a really key bone. And in congenital vertical talus, instead of pointing at 45, in a normal foot, it will be at this sort of angle. Is that clear on the screen, Loredana? But in a vertical talus, it points right down. It's more like this position. So you can see that the head of it, if I just come in a bit closer, is pointing down into the sole of the foot. Okay. So instead of being at a normal foot position where it's at sort of, probably this way around is better, sort of 45 degrees, in a vertical talus, it's pointing right down into the sole of the foot. This bone here, the navicular, this is this one here. So in vertical talus, it's pushed round to the side. Can you see that it's come, this is the ball of the talus, and the navicular bone is pushed round to the side. Okay. So it's pushed sideways, and the middle part of the foot bends up and outwards, and that gives the impression of a rocker bottom. And you can see that on the photograph really well, that there's that sort of rounded appearance. Now, to go along with that, the back of the foot actually is tight. The Achilles tendon is tight, and that's pulling that heel upwards, but also lifting it outwards. So if this is your normal foot position, let me just get it back in. There's your normal heel. As I take it into vertical talus position, do you see that the heel bone sort of rocks out a little bit? Yeah, okay. So the Achilles tendon is tight, and that's what gives this impression of lifting up the back bit of the foot. Okay. Next slide, yeah. So, very simply, the foot is held up and outwards. The baby can't fully point the foot down and in, and you can't actually passively, if you take hold of the big toe and try and pull that foot down and in, you won't be able to get it right the way down and in. So you can see in this baby, they've got a vertical talus on the right foot, and actually the left foot was a much milder version, but wasn't quite normal, but was a milder version. And that was what's called an oblique talus. I'm going to talk a little bit about that in a minute, which is a slightly less severe version of vertical talus, where the talus bone is not pointing right down into the sole of the foot, but isn't at 45 degrees either. So you can see the rocker bottom appearance of the foot on the right side, not so much on the left. And actually, if you were to go in and feel the heel on that right foot, it would feel a bit soft and spongy because the heel's actually being held up a little bit. Okay, next slide. So we see children come through with lots and lots of different possible diagnoses when they're first referred with congenital vertical talus. Quite often, we're told that the child has talipes. Now, talipes just means of the foot. It's not actually a diagnosis, and it's anything to do with the foot. So that's very different from clubfoot. Clubfoot is completely opposite deformity, where the foot is held round and in the other way. So you can see it's going the other way from the picture on the screen. So there are some children that are born with the foot pushed up and out, but when you take the big toe, you can completely correct the position. And this is called a positional calcaneovalgus. So calcaneus is the heel bone, and valgus means coming up and out. And this is a positional foot. We'll talk about treatment for that. There's also this slightly milder version of vertical talus called the oblique talus. And there are many other foot deformities that can crop up, more obscure things like fibula hemimelia, and other foot deformities that can sometimes be mistaken for vertical talus. Okay, so this is a positional foot. So this little baby's foot doesn't completely point down. It's a bit up and out, isn't it? But it doesn't completely point down. If I was doing a passive movement on this, it only just came beyond the 90 degree. So what we did is we taught some stretches, and the family went away and did some stretches, and they came back a few weeks later and they've got full range of movement. Very, very rare to need to do anything other than stretches in these positional feet. I mean, you can do a week of casting. Some centres will do that just to try and speed things up, but it's normally not necessary. It's unusual for that to be necessary. So in most cases, in positional calcaneovalgus, where you can passively move the foot pretty well, you'll do your stretches and it will resolve spontaneously with no need for intervention. Classically, the difference in this foot you can see is that the heel looks pretty normal. All right, you can see in that top picture, the heel doesn't look as if it's being pulled up. And that's a real giveaway that this is a positional deformity and not a structural one. Now, this is an oblique talus, which is a little bit more difficult to discern. And although the foot isn't stuck right up and out, like the rocker bottom picture that I showed you in the first instance, when you look at the foot from the front, they don't look too bad. But if you're moving these feet, you can't completely point them downwards, all right? You find you can only get to sort of neutral and not really pointing down. And you can see there's a very slight hint, particularly on the right side, there's a hint of a rocker bottom appearance on that foot, but it's subtle. When you turn the baby over, so this is why it's very, very important for your team to look at all angles of the foot when they're examining. When you turn the baby over, it's a little bit more obvious, isn't it? Particularly on that right side, that just the contouring isn't quite right. And really this has to be diagnosed firstly by palpation, but then by x-ray. The problem is that you can't see clearly on x-ray when the baby is really, really tiny, because you will not see the bones in the mid part of the foot when you x-ray a tiny baby. So initially, the diagnosis has to be on palpation. These oblique taluses may take a bit longer to diagnose because you can't really see it until you can do an x-ray and find out. And that's probably over 6 months of age that you'll be able to see where the talus is really sitting. And even at that stage with an oblique talus, it's not always obvious, right? So it's actually, if with a very experienced team that have seen lots and lots of feet like this, they're more likely to pick it up than a team that only see an oblique talus once in a while. Okay. So there's no real consensus of treatment with oblique talus. Some people don't treat it at all. Some people leave it and wait and see whether it resolves. Some people stretch and monitor. Some centres will do reverse Ponseti casting, and a lot of centres now will operate if it isn't reducible, but they may wait a little longer to make that decision. I don't think there's any evidence about right or wrongs at the moment. I think this is a clinical decision on how the foot responds as the baby matures, how the range of movement comes back, and what the foot is starting starting to look like. So it's very common to not pick up an oblique talus until a child's standing, and that's not uncommon to see that. And it doesn't mean it's not treatable once a child's standing. Not ideal, but it's not unusual. Okay, so a real vertical talus. Now, I think this really shows you how difficult it is to make a diagnosis from X-ray. So this is a child who's about 9 or 10 months of age, and you can see how difficult it is to see the bones in the middle part of the foot on this X-ray. So this is, so if it's a known vertical talus, certainly in the centre where I work, we probably won't do this. We won't do this surgery until 9 or 10 months of age at the earliest, because the surgeons I work with like to know that there's good bone formation. Under 6 months of age, particularly, the bones are very soft and cartilaginous. So if you're putting a wire into the foot to hold the bones in shape, into position, you don't know whether you're getting good purchase with the pin. It's also impossible to see using the image intensifier, which is what this is. It's an X-ray machine in theatre, and that's allowing the surgeon to guide that pin into place. And what they're doing with that pin is they are fixing that navicular bone that I showed you earlier with the talus. So they're fixing those into place, and they're then doing a release of the Achilles tendon at the back to let the heel drop down. Now, if they can't see where they're putting the wire, it's going a bit blind. So it actually needs to be treated a little bit later. But this is very, very, it's all done from the outside of the foot. There's no sort of open incisions here. And actually, it is done under general anaesthetic, but it's quite a quick surgery. Usually the child goes into cast for 6 weeks afterwards. Sometimes we'll do a check of the pin in 4 weeks. Quite often the pin decides to work its way out when it's ready to come out. We put the kids into above knee cast when we do this, mainly because we don't want the cast to slip off, and we want to immobilize them a little bit while they're sitting in their cast. And then they definitely need to go into some sort of orthotics afterwards, either the foot abduction brace set to 0 to 10 degrees on either side, or I mean, we put all of our young babies into the foot abduction brace for nighttime for stretching, and then they wear orthotics during the day, and that will either be AFOs or insoles, depending on the severity of the foot and how the foot looks once the child is in standing. And up to 2 years of age, they'll wear some sort of orthotics, usually AFOs. So this is just another picture on the, Loredana, if you can hover over the, I can use my arrow. Can you see my arrow here?
You can't.
You can't. Okay, so you can probably use your arrow to show the talus on this, on the dark picture.
This way.
Yeah, and that's it. So you've got the heel bone is the big bone at the back, and the talus is pointing downwards there. And then what's happened with that surgery on the right hand side, you can see you've got the wire coming into the talus and fixing it with the navicular, all right? And then that foot is pointing down, and then they will then do an Achilles tendon tenotomy, and the casts will be put on with the foot in a neutral position. That's done in theatre. So I just wanted to show you this picture, which is a child who's had a very successfully treated congenital vertical talus. So in this picture, she is 6.5, nearly 7 years of age. She is very, very fit and active, participates in lots of sport and ballet and, jumping. She's a very athletic child. You can see she's wearing normal footwear, but you can see there's a difference between the calf bulk on her right and her left legs. So I think, like clubfoot, if you have a unilateral vertical talus, it's much more you are going to see slight differences in the size of the legs and in the size of the foot. It's very unusual in a unilateral vertical talus to have complete symmetry, even after excellent treatment. So she gets no pain, no loss of function, but you can see that there is a slight difference in her calf muscle bulk and in her foot size. But she doesn't get pain, and she's got completely normal function. Right, so I think what I'd say is there are many variations in treatment, not in terms of, I think the Dobbs reverse Ponseti casting is fairly standard treatment in the UK now, but I think there are variations in how much splintage and orthotics are used afterwards. The current recommendations are orthotics up to 2 years, and a lot of centres are using the foot abduction brace at night time, set to either 0 to 10 degrees, never out to 60 degrees, not like clubfoot. So to keep the stretch on the outside of the foot, so to stop the foot coming out like that, put in the foot abduction brace to keep it stretched there so that it can't do that. Okay. The optimum age for starting treatment, there's quite a lot of discrepancy across centres. As I say, in the centre I work, we tend to do it sort of just before the child's starting walking. Maybe it's sort of 9 to 10 months of age, just because we want a bit more bony maturity. There are some centres that do it a little earlier and some centres that do it a little later. It's very important that there is enough bone density and maturity to be able to do the wiring successfully. And as I've shown you with the pictures, it does help, I think, for the surgeon to see the location of the bones in the midfoot on the X-ray in theatre, so that they know exactly where they're putting that pin. So, waiting for treatment. I think if you're worried about the fact that you're waiting for treatment because of the COVID-19 situation at the moment, I think if your child's not walking yet, you shouldn't worry. I don't think there's a disadvantage in doing the surgery a little later in a pre-walking child. If your child is walking, then I would suggest using some nice supportive footwear, maybe some ankle boots, just keep the foot. It doesn't need to be specialist orthopaedic footwear, just an ankle boot rather than a sort of flimsy little sandal. And you do want to keep the foot as mobile as possible. So whether they're walking or not walking, doing some stretches on the foot, stretching the foot. So you're trying to stretch the foot down and in, get that foot sort of pointing down like a ballerina. And it's obviously really important to keep in contact with your local service, because if they're having a big delay in going back to surgery, you just want to know what the situation is and how long you're going to have to wait. But I don't think I don't think it's a time when you should panic because you're not getting the surgery, because it can be done a little bit later with this condition.
Thank you very much, Denise. That was a very informative session on congenital vertical talus. I'd like to open out now to all the participants the opportunity to send their questions in. I know you have answered a lot of the questions we have put forward to you before, but nevertheless, I'm certain that many of the parents are listening in, have further questions that they would like to submit. Therefore, if you could please submit your question now, that would be great. And the way to do it is through the Q&A section at the bottom of the screen, or email us at info@steps-charity.org.uk. With regards to the question that we have received so far, Denise, we do have several that I would like to discuss with you. The first one is related to global development delay and congenital vertical talus. Is it common to have do the two conditions go together?
Yeah, I think it is much more common than in clubfoot. So we know that at least 50% of cases have an additional underlying diagnosis, and I think as we learn more about vertical talus, I think it's recognised that may be even slightly a higher rate. So certainly in our centre, if we have a child coming in with vertical talus, we will routinely get them checked out for other conditions as well, really, unless we're absolutely sure they look completely perfect. I mean, the picture of the little girl that I showed you, it was very obvious that she was very bright, normal muscle tone, very athletic. She walked very early, so we didn't have concerns. But any child that's slightly delayed in their walking or would be looking very specifically for delayed milestones, and other conditions. As I say, some of the syndromes that do have associations with vertical talus are not apparent straight away. So it's just not possible to see them in the very early stages of treating a child with vertical talus. But it is something that every treating clinician should have at the back of their mind and should refer to a paediatrician as appropriate.
Thank you. And this is quite a tricky question, so we have debated it before, but which tests should be done to find out if there are any underlying conditions?
So a general developmental assessment, every child has assessment with their GP and their health visitor. And I know that children coming to see paediatric physiotherapists will have a holistic approach to looking at that child. And as I say, the tests really, if there's concern about developmental delay or another associated condition, then it's really important to refer to a paediatrician or a paediatric neurologist as appropriate. So going into specific tests, I think it's a little bit more complex than that. Some children will need full genetic screening. Other children, it will be, a different picture. But it's very common, for example, to refer to a paediatrician and then for the child to undergo genetic screening.
And would you say that a child with CVT should be treated in a children's hospital with experience of a paediatric consultant?
I think it's about being treated somewhere where the numbers are high enough. So if it's 1 in 10,000, and you're at a sort of local district general hospital who only sees maybe one vertical talus every 2 or 3 years, it might be better to be treated in a bigger centre. But it depends on the experience of the team. However, with the complex vertical taluses, things like spina bifida, arthrogryposis, and some of the very complex syndromes, if it's a very stiff, rigid vertical talus, I do think that needs to be considered to be treated in a specialist children's orthopaedic centre, because they tend to be much more difficult to treat, much more difficult to cast, and they need that experience to decide when and how to do surgery.
Thank you, Denise. Another question that has come in is, what's the success rate after the first operation?
Okay, so any operation doesn't have a 100% success rate. There's no such thing as an operation that's 100% successful. I think as somebody that's been in peds orthopaedics for more than 30 years, I can say that Dobbs' reverse Ponseti method coming into play has transformed the way that vertical talus is treated. It's treated earlier. It's a very non-invasive procedure. So even if another surgery does have to be done, then it's leaving your options right open. It's certainly my experience is it's very rare to need to do any sort of major surgery following reverse Ponseti casting, but a bit of that depends on the original presentation. So in a child with spina bifida or arthrogryposis, where the foot is very, very stiff and resistant to casting, you're much more likely to need more than reverse Ponseti casting. With a foot that casts out beautifully, then you're unlikely to need anything more doing. And even if you do need anything more, it will probably be quite minor soft tissue type surgery. But with the very stiff syndromic feet, that's likely to be a different situation.
I'm talking about reverse.
Sorry, that doesn't really answer the question, but it's very difficult to be very specific, because talus, like clubfoot, there are degrees and degrees. There's no scoring, grading system for vertical talus, but it tends to be sort of managed on terms of stiffness and rigidity of the foot, really. So the more rigid the foot, the less movement you get in the foot, the less likely you're going to have a successful result. And if you can't cast that foot out, then if you can't cast it out and get full range of movement with the casting, so that you're relocating that navicular with the talus, then you're not going to be able to do the Dobbs technique.
The reverse Ponseti method, the casting technique, could you explain a little bit more? Because we have a question as to what does it involve?
The casting, okay. So the foot starts off in this position. Is that clear on the, and you gradually over a period of weeks. So it's exactly the opposite from clubfoot casting. So in clubfoot casting, the foot starts here and you cast it out. And in vertical talus casting, the foot starts here and you cast it down, 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 down and in. So that you actually have the foot pointing down, so that the talus and the navicular are in line and relocated. The talus is relocated to the end of the navicular is relocated to the ball of the talus, the end of the talus, tailor head. Okay, so it's the opposite. So you cast, and that's done over a period of weeks, just like clubfoot casting. Normally weekly changes of cast over 4 to 5 weeks, maybe, and then normally the difference is, I mean, certainly in my centre, we'll take an X-ray to confirm whether we've got that location right.
Perfect, thank you very much. And one last question that we have here with regards to supportive footwear. What would you recommend? What's defined as a supportive footwear?
I don't think I can recommend one make over another. You know, so there's a lot that's available on the high street that's or online. No high street at the moment, but there's a lot that's available online. So places like Next and Marks and Spencer's and Tesco's, Asda, they often have good supportive footwear. It tends to be more in their winter range than their summer range, but you know, it is out there. In very severe cases, you know, some kids go into things like Paediatric boots, but they're terribly heavy and hugely expensive. They don't really need those generally. It's much more common for us to manage the children in nice supportive footwear, and maybe with an insole, with a molded insole with an arch support, which our orthotists will make. So we'll quite often do that sort of supportive footwear. So a normal high top sort of boot, little ankle boot, lace up or Velcro, and then a molded insole inside that.
Perfect. That was our last question for today. And I would like to thank you, Denise, for your time. Much appreciated, especially with what's going on with COVID-19. For those of you that would like to submit further questions, please do so via info@steps-charity.org.uk. And have a nice rest of the day. And thank you very much, Denise. And
thank you. My pleasure.
Thank you. Bye-bye.